Hi, this is Emma Krasansky in collaboration with Dr. Christopher Steele presenting Health Equity Teachers Module, Women's Health Inequity. The objectives of this module is to summarize how the historical roots of medicine, healthcare, and research continue to impact women's health and healthcare, give examples of gender-based health and healthcare disparities that exist in the United States, and describe different vulnerabilities common to the women population and how they impact women's health and healthcare. So to begin with, in order to understand the current state of women's health inequity in the United States, we have to understand how the country itself, its institutions, and especially healthcare was built in preference for men. And so this goes back to when our country was founded and the patriarchal society that existed and continued for centuries until the women's movement really picked up in the 1900s. But specifically in healthcare, we saw that it was truly built on men and for men, as all of the data for practices, drugs, treatments all came from men. Until 1988, clinical trials for new drugs by the FDA were routinely conducted predominantly on men and excluded women. That means that the development of these diagnoses, preventative measures, and treatments were all based on data from men, and that data had to be extrapolated to women, meaning that we had no idea how these treatments would be received in women, and they were given them anyways. Women were prescribed doses that were meant for men's data, their weights, their metabolisms, and this puts them at risk for adverse drug reactions and death. We see that with, just as examples, we see improper implementation and adverse reactions with antithrombotic agents, blood pressure medications, and antidepressants. These all act differently in women than they do in men. And so in addition to drugs potentially being harmful to women because they were designed for men, we also see that because of the exclusion of women in clinical trials, drugs that are potentially beneficial for women may be eliminated because they might not be beneficial to men in these clinical testing studies. Now, this history of clinical trials is really only part of the women's health inequity roots that are in medicine, but it's very important to recognize as future providers. Since the 1900s, in 1990, there was a founding of Office for Research on Women's Health at the NIH, and this focuses on equal representation of women in clinical trials and other health equity measures within research, so that we can start combating and reversing this patriarchal focus within clinical trials and begin creating equity for women within drug treatment, preventive measure creation through scientific research. Now, because of these historical roots of gender inequality within healthcare and medicine in our society, we see certain health trends. And to begin with, women actually have longer life expectancy than men by 5 years. And women also have lower age-adjusted death rates than men for 12 out of the 15 leading causes of death. People may look at this and say, well, women are doing just fine, they're doing better than men. But in reality, disparities are present within many areas of health and healthcare, and we see this in every specialty. You look deeper and you see that women have disparities regarding their health and the way that they're treated within the healthcare system. Just a few examples here that women are more likely to show signs of depression and anxiety than men are. Women are more likely to die following a heart attack than men are. Women are more likely to experience delays in emergency care than men. Women are more likely to have a stroke. 1 out of 5 women have strokes statistically, which is huge and a lot higher than men. And women also can experience more serious effects of STDs and STIs when not treated properly, because the way that the reproductive systems are anatomically, the infection can cause inflammation of the fallopian tubes and cause serious effects like infertility even. So these are just a few examples of the disparities that are present in different subsections and specialties of medicine, and there are plenty more. So I encourage you to do some research within your area of medicine to figure out what the disparities are that women are facing in your practice. But I think the bigger idea, even more so, it's great to know the disparities that women are facing in health and healthcare, but what's really important to understand are the factors that underlie those disparities. So what are making women vulnerable as a population? And one of those things is competing priorities. So women have a ton on their plate, and this includes taking care of children, taking care of the home, taking care of elderly or ill parents or family members, and work. So 48% of women between the ages of 18 and 64 have a child younger than 18, meaning that they're their dependent and responsibility. And the majority of women with young children have the primary responsibility over men or fathers for coordinating children's health care and staying home to care for sick children. In the United States society, it is the traditional historical cultural practice that women are those primary caretakers, if they're the ones that are at home. And that's starting to change as women are really taking charge in the workforce, but it also creates this environment of competing priorities for women, that they are on top of everything, and it takes a toll on their health, because if they are taking care of their children, if they are working, if they are taking care of the home and family members, then how are they going to prioritize their health? So with all of these things that they are in charge of, it can cause difficulty prioritizing their own healthcare needs, leading to poorer health for women. Another aspect of vulnerability for women is poverty. So women experience increased poverty rates compared to men throughout their lifespan. And this can be a result of lesser social and economic power, more limited in pursuing higher education and employment opportunities, having a higher burden of unpaid and hidden work like housework, childcare, and being more likely to work in low-wage, high-stress positions in the service industry. So those are all present trends, and they can all lead to increased rates of poverty for women compared to men. And families headed by single women are especially at risk for poverty. 30.9% of all female-headed families were poor compared to 6.3% of married couple families. So on top of women being at higher risk for poverty over men, women who are single and who are leading households singly are even at higher risk for being poor and experiencing poverty than men. And what does poverty mean for health? It can cause so many different things, especially in terms of social determinants of health. It exacerbates most in social determinants of health, whether it be food insecurity, transportation, homelessness, and everything else socially. But poverty also has been seen to be associated with worse self-rated health status in women and higher rates of many chronic illnesses in women. Poverty has been associated with higher risk for acquiring disease and having poor health overall, having higher risk for complications from disease progression, being more likely to acquire STIs and diseases like HIV. And because women are at higher risk of being poor and being reliant on federally funded programs, whether it be Medicaid, Medicare, or federally funded programs that help with social determinants of health like SNAP and WIC, women are then more at risk and more affected by the politicization of healthcare, specifically reproductive healthcare, because they're more dependent on those federal programs that are being controlled by politics. So poverty plays a huge role in women's health disparities. Another vulnerability for the women population is lack of health insurance. So in 2012, 1 out of 5 females lacked health insurance, and this could be due to a variety of reasons, whether they were ineligible for Medicaid and Medicare, whether they lacked the access to employer-sponsored programs because of their lower employment rates, or inability to pay for health insurance fiscally because of poverty rates. Now, the Affordable Care Act did help to improve the insurance rates of all Americans across the board, including women, but we do still see disparities after the Affordable Care Act was in place, because some states had the option to expand or not expand their Medicaid eligibility, and because many states decided not to expand their Medicaid eligibility, 2.4 million women were just then left and denied Medicaid when they would otherwise been able to receive coverage. So we see, even today, after many efforts throughout the past decade to improve healthcare, that women still suffer from lack of insurance coverage. And health-wise, being without insurance, we know is associated with being more likely to postpone medical care, forego getting your medications that have been prescribed for you, delaying or postponing preventive care. It can also be associated with being less likely to receive prenatal care, which is huge for women and children. It can increase the risk for poor maternal and infant outcomes. And generally, it can lead to poor health outcomes and being more likely to have uncontrolled medical conditions. So again, the lack of health insurance within the women population is a huge vulnerability for health disparities. And this is just an image that shows you within the women population which populations and subpopulations within this population are at highest risk for being uninsured. So we see that poverty is a huge factor. Being a woman who's uninsured, so as being a single parent, having a lower education level, and then being minority populations, being Black or Hispanic, and then being undocumented and not being a citizen within the United States is the highest risk factor within the women's population for being uninsured. So those are all things to consider as you're working with patients, what populations and subpopulations they fall into, and what you might need to be more aware of and ask them about when considering their health and healthcare. Now, another factor that makes the women population vulnerable is that there is a great amount of intersectionality within the women population. And what this means is that minority women within the women population also experience discrimination bias on the basis of their race and ethnicity. So not only are they discriminated on about their sex and gender, but also their race and ethnicity. So it's two factors that they now have to deal with. And we see that this takes a toll on the health of minority women. We see that women of color have poorer health outcomes than white women generally. More specifically, African American women have more pregnancy complications or at higher risk for chronic illness than white women. Women of color have higher risk of diabetes, lower rates of preventative care, and are less likely to be offered important healthcare interventions within treatment. And while we know that race and ethnicity and their healthcare disparities are very closely tied not to the genetic and cultural makeup of the race and ethnicity, but their social determinants. Even when those social determinants are, like income, are controlled, health disparities still continue. So we see that it's not just their income that are causing these poor health outcomes, but there are other factors that they are experiencing socially, mentally, physically, because of their race and ethnicity and because of the system that we have in place in the United States that make them especially vulnerable because of their gender and their race and ethnicity simultaneously. Another vulnerability factor for women's health is violence. Violence is very prevalent within the women's population, unfortunately. 35% of women worldwide have experienced intimate partner violence or non-partner sexual violence. 1 out of 4 women in the United States will experience domestic violence within their lifetime, and 1 in 6 women have experienced an attempted or completed rape. And these particularly high rates of violence have significant consequences for women's health. We see that violence is associated with higher rates of physical and mental illness, higher rates of HIV because of the sexual components of violence, as well. Because of these poor health outcomes physically and mentally, providers really need to know how to screen for violence, intervene with violence, and refer patients to adequate supportive services that will make sure that they are taken care of physically and mentally because of their violence. And lastly, the last vulnerability that I want to talk about in terms of women's health is the social aspect. So we have certain attitudes and stereotypes, discrimination towards women that are present in society because of the patriarchal historical roots of our country and our institutions that negatively impact women's health. So when it comes from women themselves and their attitudes about themselves and consequences that their actions have, we see that women are more reluctant to report symptoms because of fear of being thought of as a hypochondriac. We also see that women experience embarrassment when talking about sexual practices and behaviors, and that can discourage them from fully achieving reproductive justice and reproductive equity with their healthcare providers. We also see attitudes that are towards women from other individuals, and they include stereotypes like women make excessive demands, women's complaints are influenced by emotional factors, and women must have a psychosomatic component to their illness. And all these stereotypes, these are just a few of many present within the United States society about women. All these impact females' health, their comfortableness with providers, their likeliness to express their true symptoms and thoughts, and the treatment that they then receive from the healthcare system in terms of proper preventive services, treatment, and then their resulting health outcomes. So this wraps up our general discussion on women's health inequity, why the roots behind women's health inequity within the United States, and then the major vulnerability factors that are that are making this population so vulnerable to poor health and healthcare disparities.